So I'm sure those of you who came to the workshops yesterday, some of the photos you'll have seen, and I've got a few before and after photos at the end just to show that treatment can work. But these are just some of the examples that have come through our clinic doors, and I know that you in the community probably see this and worse as well. So what can we do about all of this? Well, lymphedema, firstly, what is it? It's a chronic swelling. It's an accumulation of fluid that shouldn't be in the tissues. It's present for more than 3 months, and it can be quite debilitating physically and emotionally to people. We also know historically funding when it comes to lymphedema services is always cancer related, and most of the research to do with lymphedema is cancer related. Yet we also know there's a big unmet need for people who have chronic edema or lymphedema due to other causes or reasons. We also know this is an incurable condition, hence the term chronic condition. So we really need to be looking at how best we can teach people to manage their own condition. Literature has recently shown that 2 per 1,000 people have got a form of lymphedema or chronic edema. And if you look at research as well, they say 1.5 per 1,000 people have a leg ulcer at some stage, and that people with MS is a 1.1 per 1,000 population. Now, if you think of all the money that goes into leg ulcer treatments, MS, diabetes, yet we know lymphedema, chronic edema has a higher figure. We just don't have that funding that the other chronic conditions do, and that's something we're fighting to acknowledge and have recognised in the health boards. In Wales, we've got a population just under 3,000 people, and if we look at this 2 per 1,000, we're estimating about 6,000 people should be seen for chronic edema or lymphedema. We also know that research is showing the prevalence of someone getting chronic edema increases by 4 times once they hit the age of 65 or more, and goes up to 7 times more likely once you are 75 or older. Obviously, your whole system is changing, your vascular system especially, which is why they tend to become more chronic edemas. In venous disease, research shows that 0.5, nearly half per 1,000 people will get leg ulcers, and those people are not being properly recognised to have chronic edema. They're diagnosed with a leg ulcer, but the chronic edema side of it isn't always being addressed either. So we've worked out in Wales, if the population of people in Wales, according to the leg ulcer statistics, also have the chronic edema, we should actually have, 5,500 people on our books. That's 5,500 of the 6,000, yet we know there are many, many more people out there. So we know there's a huge unmet need just in Wales, never mind England, Scotland and Northern Ireland. Wales is because that's where I'm from, see. Not originally. Right, types of lymphedema. You get a primary lymphedema, and this is where somebody's born with a problem to the lymphatic system. It can be present at birth, but usually manifests itself later on in life. Secondary edema is the more prevalent one, and this is usually due to secondary causes, such as parasitic infections, unfortunately not in the UK, but certainly in tropical regions. Cancer treatments, whether it's tumour obstruction, whether it's a surgery, whether it's a radiotherapy, trauma, you've got your vascular diseases, you've got your immobility. The list is actually quite endless. And you do have a small minority where there's a fictitious edema. Very rare, very difficult to treat. So how do we classify edema? I've tried to understand it because when I joined lymphedema about 8.5 years ago, I couldn't understand what the fuss was between lymphedema, chronic edema, because it's edema at the end of the day. However, I now understand that lymphedema is under the umbrella of chronic edemas, and we need to try and differentiate because these people need a different approach at the best of times. So lymphedema is really where there's a problem with the lymphatic system. So the fluid in the tissues can actually not be taken away by the lymphatic system because they're incompetent. The other 2 causes, your lymphovenous and your dependency edema, is actually a problem in the system. There's a systemic problem that actually floods the tissues, which causes a problem for the lymphatics because they will only work to a certain percentage and then they reach time out. So it's understanding what their backgrounds are. Signs and symptoms. when these people come to us, we need to understand how long they've had the edema for. Is it progressive? Is it regressive? What is their experience? Does it fluctuate? Now, true lymphedema does fluctuate. It goes up and down on a day-to-day basis and probably throughout the day as well. In your more lymphovenous cases, your really chronic lymphovenous, they tend to stay static after a while because the tissues become so fibrosed. Does the edema reduce with elevation? Does it reduce overnight? Does the edema pit? Stemmer sign, is that positive? So pinching the skin. And that again is a true indication of an edema or chronic edema. And what does make that edema better or worse? Ask your patients, because that's where you need to start focusing on. If you can find a factor in their lifestyle that actually improves their edema, home in on that, it helps. Over time, we know that subcutaneous tissues become thickened, hard, non-pitting. The skin can become very dry and flaky. You get all sorts of complications, which I'll just highlight in a minute. But basically, the older that edema is, the less it will reduce with any elevation. The skin texture, what is that like? Is it soft? Is it hard? Is it fibrotic? Are ulcers present? What's the shape like? Is the lower leg bigger than the thigh? Is the lower arm bigger than the upper arm? Or is the proportion just completely skewed, where the lower leg might be normal, but the thigh is absolutely huge? Different causes cause different types of swelling. With the skin folds, they can be either lymphedema related or, unfortunately in today's day, obesity related is becoming a bigger problem. Does the limb ache? Is it heavy? Obviously, the bigger the leg, the heavier it is, and that does cause mobility problems. In the UK, what we're tending to use are two types of grouping, how to group these patients. Internationally, you've got the ISL Staging, and that is used in most of the research literature. In the UK, the British Lymphology Society has also come up with a grouping system to try and categorize people and almost act like a triage system to see who needs the most, who needs the most urgent treatment. Internationally, there is no real consensus because Japan's got their own, Australia's got their own, Spain's got their own, you name it, different countries might have different formats, usually linked to the ISL staging, but always slightly varied. So we still need to work on an international staging consensus. Other factors we need to consider is what is their mobility like, what is their range of movement like, what is their muscle strength like, because ultimately if you don't use it, you will lose it. Physio hat on, see. What is their sensation like? If you have a huge amount of sensation, they can actually lose some of the superficial sensation. Again, quality of life, that's a big one for these patients, and weight management. I'm not going to harp on that one today. Psychosocial factors. Emotionally, a lot of them suffer an altered body image. A lot of them describe their legs as tree trunks, big and ugly, or if I could cut them off, I'd be happier. And it does show those sort of depression moods. Relationship difficulties come into it. Reaction of other people. Once they've got those bandages on, people are always asking, well, what happened to you? Did you break your leg? No, I've got lymphedema. Oh, well, what is lymphedema? And what should be a quick, how are you, becomes a marathon session for some of these patients, and they actually lock themselves indoors. Practically, what can they do? Can they still hang their washing up on the line? Can they climb the flight of stairs to their bed? Financially, are they still able to work? If not, what are the barriers? So the complications, there's a whole list of them, and I'm not going to go through all of them because I think you know them. It's not an exhaustive list, but it has a lot to do with the skin that becomes problematic. It can weep, it can become nodular, infected. The ulcers can become quite a problem as well with these people. And then cellulitis, I think that's the bane of our lives at the best of times. So just very briefly, cellulitis, it does present differently, and we need to get treatments started for these patients really quickly. But at the same time, we also need to recognize when is it inflammation versus true cellulitis. And blood tests don't always show up a true cellulitis. So, cellulitis, very briefly, it's disabling, it can be very painful, those arms or legs really swell up, become red, become hard to touch, people feel quite ill with it, almost like flu. They can get nauseous. And what we have found is that 29% of people with chronic edema and lymphedema will at some stage develop cellulitis. Now, in a clinic, we know this is actually underestimated, but we do know that with treatment, this group of people will not recur a cellulitis attack. Probably 8 out of 10 of them won't have another attack, we hope. 27% of these people will be admitted to hospital for IV treatment, and you can think what the cost of a hospital stay is with all the antibiotics. Then they get discharged into the community with more antibiotics. So it's a huge cost, not just to the patient, but to the NHS as well. Now, the BLS and the LSN, that's the Lymphoedema Support Network, and the British Lymphology Society, got a group of doctors together, and they've come up with a consensus document for best management for cellulitis in lymphedema, chronic edema patients. This document is reviewed annually, so do look at the website. I've just put up the BLS website because it's very useful. On the front page, they have some idea of what's going on, and they explain why they ask for some groups of antibiotics versus others. So it's a good read, and it's a good reference as well. So, assessing your patient. Where do we start with some of them? My instinct would be to get in there hands-on as quickly as I can. However, we do need to look at their subjective history. We need to understand the nature of their condition and how it's affecting them. We need to know what their medical background is. What other comorbidities are they bringing with them? What medication are they on? How's that going to affect the edema treatment? Psychosocially, what is their view on the edema? Do they actually want treatment? That's a question I've started asking. What are their hobbies and activities like? Do they sleep in the bed or do they sleep in a chair? That's going to impact on our treatment as well. And then again, quality of life. What motivates them? Why do they want to be in the clinic today for an assessment? And we've had a few that have said, well, I've just come because I've been told to come, and actually I don't have edema, yet they've got ankles that are filling their shoes. So it can be very interesting on people's perception of how they are. Objectively, we need to look at the skin. What's the temperature like? What's the colour like? What visual complications are there, as in infections, as in wounds? Tissue, we palpate. We actually have a feel at the tissues to see, is it pitting, is it non-pitting? What's the stemmer sign like? What's the distribution of the edema? Because sometimes it could be soft in one part of the leg and quite hard in the other. So it's to find out what that edema is doing in the leg. Weight and height is taken, so we have a baseline body mass index indicator for us. We know what the BMI scale is like. It's an indicator. It's not a definition. But we have found that more and more people are hitting the 40+ BMI index. Circulation. What we do in our clinic is we do a skin test. So again, you do your capillary refill, we check for blanching, we check for hair loss, we ask the patient about intermittent claudication, and if there's any concern, we will then send them for a further vascular assessment. However, we find if our practical assessment is good, we'll start them on a low level of compression and monitor them. So we don't I know it's sort of debate. We don't do a Doppler on everyone because, again, someone with a massive edema, how accurate is that Doppler test? So we do look at the sort of toe brachial plexus index. We also do circumferential measurements. That's in our clinic, but there are different ways of measuring a limb and doing different investigations to see what's going on. So you've got a volume displacement, big tanks of water that you can measure how much potential fluid or volume there is. The limb circumference is very useful if only one leg's swollen. However, if both legs are swollen, you can't tell your patient, oh, you've got X amount of edema. However, that becomes a baseline for treatment to see how effective it is. So you can start telling the patient, oh, you've come down by so many milliliters. You've also got bioimpedance, which is becoming more and more prevalent. It is quite an accurate indicator of how much fluid is in the tissues as well. You've got tomographies, you've got MRI, you've got ultrasound, and a useful tool if you really want to understand a primary lymphedema, to find out where exactly in the lymphatic system the problem is. A lymphoscintigraph is useful, and that you ask your GP to refer the patient to a nuclear medicine department. It's quite an inexpensive test. It sounds very posh, but it's quite inexpensive. Right, so why do we need to measure? Well, we need a means of monitoring the patient's condition. We also need to do it as part of an evaluation to make sure that what we're doing is effective. It's an outcome measure. Certainly in Wales, the Welsh Assembly Government is demanding of us evidence and proof of what we're doing is effective, and circumferential measurements are proving to help us a little bit. Again, we need to take measurements because without them we cannot issue a patient with the appropriate garment. The last thing we want to do is tourniquet their ankles. Treatment. We rely on the 4 cornerstones of care. In lymphedema, there's loads more to this, but this is the absolute basics. And if a patient can't work with the basics, you have an uphill struggle from the start. And the most important part of the cornerstone is skin care. And this really is a patient's responsibility. It's their leg, it's their skin, it's their responsibility. Exercise and movement needs to be encouraged as part of a weight management program. There's lymphatic drainage that can be taught to them, and then compression. So skincare, what is it? It actually means physically washing the skin. Bucket of water, get your soap substitute in there, and get the patient and or their carer involved, actively involved. There's no point having them as a passive person, because once you withdraw your treatment and they can't do that, you're back to square one within a few weeks or months. Click. Drying the skin, preferably with a clean towel. Pat dry so that you maintain the integrity of the skin, and dry thoroughly between the toes. Obviously, if you're working with an arm, dry thoroughly between the fingers. These are basics, and it's things that you and I might sit and think, surely that's obvious. But, you know, these patients have been passive for so long, they've actually forgotten how to do the basics. So we need to teach them. To moisturize daily, or if you're bandaging, at each bandaging session, put some cream on. And the rule of thumb that my tissue viability nurse taught me was use cream for wet skin and ointment for dry skin. And yesterday was quite interesting in the workshop, because everyone was, well, what's wet and dry skin? Well, wet skin is somebody's skin who's normal. It's got a good integrity and it's self-moisturizing. That's the likes of you and me. Our patients who have chronic edema have dry skin, flaky skin, they might have exudate, they might have lymphorrhea, and they need an ointment to really give good nourishment or to act as a barrier to the lymph fluid or the exudate. So that's where she's come from with that little rule of thumb. Exercise and movement. We need to encourage these people to move as best possible within their limitations. They can have exercises in the bed, you know, ankles up and down, exercise in the chair, standing up, walk on the spot. What I was trying to share yesterday's group, if they get bored of going up and down with their feet around and round, get them to draw the alphabet. Keeps the brain busy as well. We try and think out the box. Something as simple as deep breathing exercises, thinking of people who are bedbound and might be paralyzed, they can still breathe. Teach them breathing exercises. It's fantastic at promoting and stimulating lymph flow because of the gut, the lymph nodes in the gut being stimulated. It helps drainage for the legs as well, and anyone can do that. Obviously, elevate the leg when resting. Patients take that quite literally when their GP says you need to put your feet up. And then you come and say, but you need to exercise. And the patient goes, no, but my GP said I need to put my feet up. It's to get a balance, help them understand they need to move, and only when they're sitting do the feet need to go up. Weight management. We know chronic edema is a comorbidity of obesity. There's no argument to that. Evidence shows that an increase in weight will also exacerbate any underlying edema, because quite literally the fat cells squash the lymphatic vessels. They become more and more incompetent, so the fluid backs up. Advice and support is needed for this group of patients to encourage them to take part in a more active lifestyle and to look into weight management or reduction. Again, it's about perception, because people I've known who are 40 stone don't perceive themselves as being fat. They're big and they've got swelling, and that's their problem. Big boned. So we need to help them understand that actually they have a condition that needs better support. It's true. Go on. So lymphatic drainage, there are 2 types. There's a simple lymphatic drainage which we can teach our patients or their carers to do. It's just a few stroking techniques. But as lymphedema therapists or specialists, we actually are taught to do a manual lymphatic drainage technique, which is far more intensive and we can do it in conjunction with some of the bandaging, and it really helps to soften the tissue and get that fluid off the leg or the arm. So compression, garments. You just have to walk out the door there to understand the variety of garments out there. And it's to decide which ones to go for. What material do I use? What compression level do I use? Do I use a below knee or a thigh? There's so many modifications you can have to these things. They can have pads, they can have zips, you name it. You can become quite a fashion designer sometimes with these things. But it's trying to decide which is best suited to your patient. Bandaging. Again, there are many types and styles of bandaging. And as a lymphedema specialist, I used to say, oh, the bandaging we do, that's the only one, it's the golden standard, that's what you've got to do. What I have learnt over time is that the different types of bandages that are out there are because people are not all the same. So we need to use a bandage system that's best appropriate to your patient, but it's about the application and how you use that bandaging so that we don't get legs coming into our clinic that look like that. All right, so the aim of the bandaging we do, which is multi-layer lymphedema bandaging, we're not cruel by making them look bigger than what they are, but it is to improve the skin condition, it protects fragile skin, and it will stop lymphorrhea hopefully within 24 to 48 hours, and it does reduce pain and discomfort. Obviously, if people are palliative, we need to take a bit of consideration in how much tension we put on our bandaging. The garments. This is just a small table to just highlight the different levels of compression and the different areas we can access garments from. And what I'm still getting from my patients is, oh, I bought a lovely pair of support tights from Marks & Spencer's. That's fine, I don't need my compression socks anymore. And you say, okay, come back in 3 months, let's have a look. You wear yours and we'll bear in mind. And they'll have gone up in volume, no doubt, because it's less than 10 millimeters mercury support they're getting. Whereas a class 1 garment that we'd like to give, which is the European standard, you're looking at 18 to 21, so almost double that. Okay, and that's the lightest compression that we would like to give our patients. Factors we need to consider when choosing a garment. What is the size of that leg? What is the shape of the leg? How many skin folds are there? How much swelling is still there? Because if you whack on a compression garment on a big leg and it's a soft edema, probably in 6 to 8 weeks, that patient will be back needing a smaller garment. So in those cases, it's best to bandage, get rid of as much fluid as you can, and then choose your garment. Again, what is the patient's age? What's their previous medical history? And what are their social circumstances? Can they actually get that garment on that you're going to order? Or do you need to make sure that there's someone that can do it for them? Again, can they fit into something that's ready-made? Or do we need to do something that's a special order, your made-to-measures? Again, circular versus flat knit material. And again, in the workshop yesterday, I explained the difference, the basic differences. If a patient has a normal shaped leg, circular knit is good. Anything other than that, try the flat knits first. Patients will prefer it, and they are far more concordant with it as well. Again, what level of compression? You get class 1 to 4. You get British standard, you get European standard. Do they fit into the ready-to-wear colours? You get black, white, beige, brown, purple, green, you name it. A lot of these colours are out there these days. Toe caps, open toe, closed toe, with a grip top. And if you have a grip top, which kind? One with dots, one with solid silicone, one with lace. Okay, your options are actually limitless, and that's why I said you could become a fashion designer with these things. But always take into consideration a patient's allergies. Okay, there are materials out there that can help for people who are sensitive to some of the silicones. Applying the garments. Now, time is needed to teach a patient to actually put it on. And if you know a patient can't do it themselves, their carer does need to be present. It's all very well teaching and demonstrating, but unless you actually observe the patient or the carer doing it, don't let them out that door, because they'll go, yes, we can do it. And then when they come back in 6 weeks' time, they've not worn the garments because they've not been able to get them on since they took them off. So do check. There are aids out there. There are different slide applicators. There are rings, or I've called it plastic tubes because there's something called an easy as well that looks like a half moon type tube thing. There's loads out there. But something that's very useful to the patients is a rubber glove. It helps with the traction of pulling the garment on. Compliancel Concordance. patient's behavior, their attitudes, their ability to take the garments on and off. All of that is going to make your treatment successful or put you back to square one. Again, the compression therapy you want, is it a therapeutic compression, is it a curative compression, or is it a palliative compression? And what patients don't always understand and appreciate is chronic means lifelong, and it is a lifelong change in lifestyle. So does treatment work? I hope so. I wouldn't be in a job otherwise. Right, this is a gentleman that came to our clinic, gosh, many years ago actually, it's about 8 years ago. He had sarcoma, he had surgery and radiotherapy to the groin, and when he came to us, it was a 280% difference from the affected leg to the other leg. 3 weeks of intensive bandaging and massage, and you can see it's reduced to 27%. We've maintained him more or less in that region since then. Go on. Spina bifida. You can get really bad lymphedema from that. And again, this patient, now both legs are affected, but the worst one was 350% bigger to the unaffected, to the other leg. Again, 4 weeks of treatment in this case reduced to 60%. This was 5 years ago. We've seen her since, and I just couldn't find the slide again. But she's actually reduced to 35% difference now between the two legs. Huge difference. And that's 4.5 stone lost in those 4 weeks. That's a huge amount of fluid. I don't think she ever got off the toilet, to be truthful, bless her. Right, toes. This is, again, something you'll come across in the community. This gentleman's toe, no word of a lie, was as big as my fist. It took a lot of hard work, blood, sweat and tears almost, but he's actually got normal toes. The after photo there was 3.5 weeks after toe bandaging that we did with him. We did a combination of individual toe bandaging and stump bandage. And he came into clinic actually 6 weeks ago, and he's in toe caps, and his toes are normal. They look like normal toes now, but it's taken a very, very long time. But even after 10 years of edema, because that's 10 years old by the time he came to us, we can make a massive difference. The cost. Again, in a year, this gentleman had had treatment in the district 6 years. He'd had numerous amounts of bandages, dressings, never mind all the district nurse visits and so on. And he had 23 treatments in our lymphedema clinic over 1 year. And we worked out that it cost the primary care sector £10,000 just in that 1 year. So it does make a difference if you can get the right bandaging, the right dressing, and the right compression garment afterwards. It really makes a difference to a patient's life. So in conclusion, lymphedema can occur in any specialty, in primary and in secondary care. It can be well managed and even prevented. If you notice a patient is at risk of lymphedema in that they've had surgery for breast cancer or for gynae cancer, or you know they've got varicose veins but they haven't got any clinical symptoms of edema yet, get them to do the basics, get them to look after their skin and get them to be active. Those two things will make a huge difference to that patient and probably delay any onset of lymphedema if they ever get it. Treatment can radically improve a person's quality of life. Some of those photos you can see that patient, in fact the spina bifida patient had sensation after 22 years of no sensation on her thigh. That edema came down, she could actually feel her knee again. So it does make a big difference. And collaboration, I'm not going to deny it. We work very, very closely with our district nurses and our tissue viability nurses. It makes a huge difference to the patient care. And then I have to just put that slide up to brag. We've actually won loads of awards, and we're hoping to get a few more in our clinic. Our walls are getting full now, and we've actually got a special cabinet as well. So put yourselves forward. If you've got a good team, put yourself forward for the awards. It makes a difference, and I tell you what, it'll get your health boards putting their heads up and going, what's going on there? Thank you very much.
Thank you.